and answer on your question. So don't hesitate, be active, ask your question, raise your hand. Please feel free, write your question in the chat. Please pay attention, this session will be via recording, and you can find more details about privacy in the chat. Please mute your microphone if you are not speaker. Okay. And I hope we are ready to start. Please, Dr. Erb, podium is yours. Thank you.
Thank you, Ulya. Good afternoon, everybody. It's my pleasure to be with you this afternoon. And I would like to apologize for my voice. I have a respiratory tract infection. I hope it will not give you some problems. Today, Sebastian, head of scientific department of OncoDNA, will be with us to discuss the cases. Hello, Sebastian.
Hello.
Hello, everyone.
And we will have 4 international speakers with very interesting cases. I'm looking forward to hear about these cases. And first case will be presented by Dr. Cheng Boon from UK. The podium is yours, Dr. Cheng Boon.
Thank you. This is Cheng. I am calling in from UK. I am the UK OncoDNA medical advisor, and I have access to the UK cases. And I will share one of the cases. Can you all see this on my screen?
Yes. Yes.
Yes.
Very good.
Yes,
So
Dr.
my name is Cheng Boon. I work in the UK, in the middle of UK. I'm just sharing a case of a 52-year-old woman who had an OncoDNA test done about 4 to 6 weeks ago. We know the history is ER positive, HER2 negative, metastatic relapsed cancer originating from her breast. She presented 5 years ago with node positive localized disease, ER positive, HER2 negative, underwent surgery, had EC chemotherapy, followed by tamoxifen and adjuvant bone denosumab treatment. Subsequently, first relapse was treated hormonally and abemaciclib. She had good partial response until January of 2023, and she subsequently relapsed with peritoneal disease with small bowel obstruction. So she had surgery, and we did the NGS on the small bowel peritoneal specimen. And the reason I brought this case up is that there are important findings in the NGS report that was not detected on other modality of testing. So the NGS has picked up a PIK3CA mutation, and other than that, the AR receptor is positive, ER remains positive. And the reason I brought this case up was because this PIK3CA mutation in the UK, we do have access, even in the public sector, with the use of alpelisib, which is a PIK3CA targeting agent, combined with fulvestrant. Now, whether the patient and the clinician decides to go for this treatment, that is their choice. Ultimately, my job is to offer options when the clinicians ask for the NGS treatment. The reason is, while the alpelisib is funded if you have the PIK3CA mutation, the test is limited by the FDA's companion diagnostics. And companion diagnostics may not pick up every single mutation in PIK3CA. They depend on what was reported in the original SOLAR-1 clinical trials. And so there's this paper that has recently been published in March 2023 about potentially detecting PIK3CA mutation that are not commonly detected even in the gold standard. And so there is potentially a 20% chance that you might miss the PIK3CA mutation if you just do the PCR hotspot testing. And so this case is to discuss this a conundrum. We have a ethical issue because in the UK public sector, the treatment is publicly funded, and therefore the test is also publicly funded. Now, if you are negative on this mutation, there's a 20% chance that if you pay for your own testing, you might still be able to find this treatment. Now, if you pay for this treatment yourself and detect it, I may or may not be able to persuade the public sector to pay for this. So I just wanted to bring this up to our international audience and see what else.
Oynayacak dedi, saat versin.
And that is my case. So the conclusion is, yes, targeted treatments are not too common. So this PIK3CA mutation, while it is more common in breast cancer, is uncommon in other tumor types. And even if there is, we don't have treatment. With advanced NGA technology, we are starting to be able to select beyond what the companion diagnostic has been able to test for. As usual, no test is 100%, so we want to get the freshest tumor samples if possible. Potentially the gold standard approved by FDA may not detect all the mutations. The question now for our regulators is, do we accept this kind of similar data without completing randomized trial? And that is the end of my topic. Thank you.
Thank you very much, Dr. Cheng. Sebastian, would you like to comment on the test before we do some clinical comments?
I don't have I would say a lot of comments. As Cheng said, yes, the goal I would say of let's say NGS, and I would say no more larger panel, is really to find treatment option for the patient. And here is typically the case when you see that the LPD-CIP, it's not linked to this type of variants detected by the companion diagnostic. So that's why sometimes we would advise to use, I would say, a complete and TGP panel to really characterize the patient, because most of the time you will find something for your patient. So yes, this is the main comment to extract from your presentation, Cheng.
Yeah,
Yeah,
thank you.
and if I may, just this is quite typical from clinical trial. They are using targeted PCR or whatever, like COBAS, and then they got approval with the FDA with some targeted tests, and you can miss a lot of mutation. And so in the US, you have the choice with a companion diagnostic, and you can have NGS, but it's really tricky to have the treatment. And in Europe and UK, the formulation for reimbursement, it's more, it's not with companion diagnostic. If you find a mutation, you can treat your patient. So obviously there is a huge benefit to test with NGS because you can miss mutation using the targeted testing only.
Yeah, thank you. Dr. Umut is asking about the pathology, but you mentioned it's lobular histology, right?
Yeah, my question is, the patient histology is lobular because of the peritoneal involvement. Can you hear me?
Yes, yes, this is a confirmed carcinoma of the breast. They had bowel obstruction, so had fresh sample from the peritoneum from the small bowel. So
Is
yes,
this
this
lobular
is
histology?
It's lobular carcinoma, yeah.
I think, let me just confirm.
Yeah, in the
Yes.
presentation you mentioned.
Okay. I missed
Yes.
it. I missed it. Okay.
Yes, lobular breast carcinoma, yes.
Is there a difference, Sebastian? Do you know the lobular and ductal histology to PIK3 mutation? You know? I don't have the number in my head. I don't think there is a clear difference between the subtype of breast cancer and this subtype of breast cancer. No, I'm not sure. Honestly, I'm not sure. No. Okay, thank you.
I think this is a clear case with PIK3CA mutation, and if available, alpelisib and fulvestrant will be a good option for the patient. And if we get the results, the
Yes.
treatment response, it will be good, right? So thank you, Dr. Chen, for sharing this case with us. And we will continue with the second case. Dr. Guy Froyen from Belgium will present us a non-small cell lung carcinoma case. Please.
Okay, thank you. So I'm a molecular biologist in the Yes Hospital in Belgium, in Hasselt. We are doing NGS for small panels since 2014, so already a long time. But we also switched a couple of years ago to comprehensive genomic profiling. So the case I would present is a male, 74 age, with lung cancer. It's a non-small cell lung cancer of the subtype spinocellular. So it's also metastatic. So based on the ESMO guidelines, he should have platinum-based chemotherapy combined with pembro. And this is also what he got in 2020. But due to severe toxicity, the chemotherapy had to stop, and he was on monotherapy of pembro. But then in 2023, he progressed on the disease after 34 cycles of pembro, and this has to be stopped. So the question was, what still can we do for this patient? So you can also see on the image the large tumor tissue type, yeah. So we did OncoDeep analysis on this sample, and we found two pathogenic variants. One is a loss of one allele of BRCA, and interestingly, the second allele had also a pathogenic mutation, a stop mutation. So there was loss of both alleles of BRCA2. Next to that, there are also a lot of other likely pathogenic and first variants, but these were mainly passenger mutations, most likely. So based on these BRCA mutations, we checked for the literature, and there was not that many patients with BRCA mutations in non-small cell lung cancer. But here are two studies which show that platinum-based therapy is sometimes reported as it has some benefit on the overall survival, and others have no benefit or are not proven benefit. So this is contradictory. Anyway, the patient could not be treated with platinum-based chemotherapy because of its side effects. So looking further at the data, we saw that the HOD was quite high. So the threshold for OncoDeep is 39, and this one is 58, so it's well above the threshold. So this is most likely due to the both BRCA mutations, of course. MSI is higher, but not high. And tumor mutation burden is also high, but depending on which threshold that you use, you can compare. You can say this is maybe low as well. So it's high, but maybe not high enough for lung. So based on this HOD high, we recommended these patients for Precision 2 study. And this study is a trial with olaparib based on this Precision 2 study in Belgium, in which patients are included that have, for all types of solid tumors, which have somatic or germline variants in the HOD genes, one of the HOD genes. So he's on this trial now. And in literature, there's also this single study where patients with a high HOD in lung, non-small cell lung, are treated with olaparib, and you see that there is a benefit, which is not a significant difference, But there is definitely a change of the overall. Sorry, I think it's the PFS, not the OS, in these patients. So there is definitely a benefit for these patients. So if you would have used the small panel, of course, you would not have found the BRCA mutation. Also, the BRCA genes are not included in the guidelines for Belgium. So we have guidelines which provide a list of genes that we have to screen in particular tumor types, but BRCA2, of course, is not included in lung, so we would have missed those. And secondly, with the comprehensive next generation sequencing panel, you can detect all kind of different mutations, also fusions and MSI or whatever. So this is the way to go, I think. Of course, there is no reimbursement yet in Belgium for that, and we hope to have it at some day, but this might take some time. Of course, going to whole genome sequence would be even more helpful, but of course the cost is higher and it's a bit more challenging for bioinformatics. You don't know what to do with all the different variants that you will find. But anyway, in the future, this will be most wanted, I think. This was my presentation. Thank you.
Thank you, Dr. Freyen. It's very interesting case with BRCA mutation in non-small cell lung cancer. Is it, do you have any other cases with BRCA mutation, Sebastian, in the group of OncoDNA?
In non-small cell lung cancer, you mean?
Yeah.
It's not that common. Probably, if I look to the database, I will find probably one or two other, let's say, patient. But this is really rare, I would say. So, and here, in fact, what makes a difference here, because as you see, the HRD is highly positive. Because of course of the absence of the two allele of BRCA2, so that also put the question about the threshold of HRD in other cancer type, of course, because it's 42 done by Myriad in ovarian, but in fact it's a little bit like the TMB. We don't know exactly where we will be for the other cancer type, but yes, of course, here it was, I would say, a little bit easy to choose a little bit a new cancer treatment for this patient, and yes, regarding this, it's not really common in our database. So I'm sure I will find one or two other patients, but not a lot.
Yeah, correct. Is there any family history, Dr. Freyen? I missed it. For this patient, is there any family history?
Well, it was tested germline, but it was absent, yeah.
Okay.
I had a question related to case.
Yeah.
And, did the patient use the pembrolizumab more than 2 years? Is it right?
Not more than, I think 1.5 years.
Looks like more than 2 years, because we used 2 years maximum pembro and then stop, and rechallenge maybe started the most practiced for us.
Yeah, it was from September 2020 till the 1st January 2023. So it was more than 2 years, yeah.
Rechallenge maybe. And another question for Sebastian. Sebastian, after you found BRCA mutation, somatic mutation, do we need the HRD testing?
Somatic mutation is a little bit different than germline mutation, because you can have an HRD scoring negative when you have a somatic mutation, but here it was not the case. And most of the time, I would say, yes, I would say 99% of the BRCA1 or BRCA2 germline mutation in patient will be HRD positive.
Yeah. Okay.
Yeah, I would like to actually comment and maybe make some, brainstorm. We have some tumor agnostic markers like, MSI, tumor mutation burden, or BRAF. It is also accepted as tumor agnostic biomarker. In the near future, we will accept HRD and BRCA maybe as tumor agnostic markers. So treatment option as in this case, PARP inhibitors may be an option, but this is actually only expert opinion, not trial-based result. But this is my feeling. Is there any comment about this from clinical oncologists or scientists?
Yeah, just one comment. For P3CA, I'm not sure because I used to test patient during 10 years in hospital doing both DNA sequencing and RNA sequencing. And the thing is, P3CA is, let's say, an exception. It's not expressed in almost all cancer type. That's why all the clinical trial targeting P3CA in lung cancer failed, for example. So in breast for sure, but P3CA, I'm not sure it will become available for all cancer.
No, not PIK3CA. I have commented about BRCA and HRD.
Ah, okay. Okay, sorry. So let's see, but for now, it's not, let's say, the strategy of biopharma.
Right.
Yes.
May I come in and comment? Thank you, Dr. Froyen. Your case is very interesting. And you raise an interesting point about doing whole genome sequencing. So the more advanced or the more treatment you've had, and this comes from my own experience as well, is that the patients will have branching mutations. So mutations in one metastasis will be different from another metastasis and another primary. And it becomes, where do you biopsy? So if you take a biopsy from the primary, is it representative of the metastasis, or do we do a liquid biopsy? So you start very quickly reach the point where, is this really HRD or is it historical? And sometimes I challenge Sebastian, if I have a 41 point, is it real or is it not? And sometimes I see a lot of, he's telling me he's missing one copy of the genes, but he just about hit HRD, but the patient is not behaving like that because they're platinum resistant.
Yes.
So that tells me that the cells are mutating and they're changing their nature. So by giving platinum, I know they're not HRD already. So sometimes I can say, Sebastian, you're wrong. So this is where clinicians have to be willing to challenge the Sebastians. I'm not going to take just Sebastian's word. I get it, but the biopsy is old, or you may not be representative. It's very hard. The hardest I have is where patients have a lot of ascites, and those ascites are active, and we're not actually testing the ascites. We take the fluid, but we can't do the histology. It's really hard, and I don't have an answer for this. I'm looking at Sebastian to come and invent a better test for us in the next few years.
Yeah, thanks.
Umut, do you have a question?
Not question, maybe comment. There was a research and also editorial a couple years ago, Nature, why we don't accept the HRD tumor agnostic, because as Boone said, each indication is different activation of HRD and not looks like a real tumor agnostic.
Good, thank you. I think we are done with this case, and we will continue with Dr. Umut Demirci's case, which is again another interesting case. Please, the podium is yours, Umut.
I tried to get full screen, but I didn't do it before. I try again. Hello, everyone. This is Dr. Umut Demirci from Ankara. I'm a medical oncologist. I have a recurrent endometrial adenocarcinoma cases. Is this works? Not?
Actually, it's the first page. It's not moving.
Not moving?
No.
Okay. Again. Stop it and again share.
Share again.
Yes. Is this work?
Yes, it's working.
Okay, thank you. 45-year-old female patient admitted to our hospital constipation in March 2023. Actually, she diagnosed with endometrial adenocarcinoma 2020. And after operation, the pathology report showed us grade 2 tumor in all cervical wall and stromal invasion more than 50% and 44 reactive lymph nodes, and then treated with radiation and brachytherapy. And in personal history, hypothyroidism and stroke, never smoker. In her family history, endometrial mother adenocarcinoma, mother endometrial carcinoma, aunt breast cancer, and maternal aunt brain tumor. Physical examination, ECOG performance status 2, dyspneic, and the ileostomy we saw. And the last 1 year, pain, weight loss, images, all of them available. And PET CT in our institution, mass lesion in vagina cuff and peritoneal carcinomatosis, and lymph nodes in the spread cervical, mediastinal, abdomen, and right pulmonary nodules we detected. And she operated with ileus, papillary adenocarcinoma, pelvic implant, and signs of perforation. And after recovery, postoperative recovery, we started weekly paclitaxel carboplatin because of the high tumor volume. And then we sent NGS testing. And again, we found PIK3 mutation, pathogenic mutation, P53 mutation, likely pathogenic. And in the immunohistochemistry part, each estrogen receptor positive, HRT negative, MSI stable, and PD-L1 negative. Immunogram likes that. And the first line chemo is well tolerated. She is on cycle 2. I have a couple questions, all the member of the board. I want to ask the Sebastian HRT analysis again because of the, is there a validation or any other comments? About this case, is alpelisib fulvestrant valuable option for you? And I also ordered germline testing. Maybe after that we can switch to treatment. The last one question, is immunotherapy an option? For example, pembrolizumab in this patient. Thank you very much.
Thank you, Umut, for your presentation. Sebastian, would you like to comment about HRD analysis?
Yes. So Umut, what is really your question regarding the HRD analysis?
Yeah, because you know the Myriad is the validated analysis for HRD in our country or anywhere, but HRD is 3 parts in Myriad. In your analysis, I know the 2 parts you have. Could you explain the differences?
Yes, in fact, it's a little bit more complicated than that. For the validation, for example, for the HRD or HRD scoring, we did really in simple way. That means that we took a sample coming from already characterized by Myriad, and we applied the same, I would say, or let's say gene panel, just to calculate the HRD and just to see if we are in line with the Myriad scoring. That was mainly the validation. And regarding this, in fact, we just succeed a CRIP ring trial in Germany, where in fact we succeed to give the good results about 10 samples already characterized by Myriad. And so, for example, now our test can be used in Germany to prescribe PARP inhibitor regarding HRD. So now regarding the calculation, in fact, we are doing the 3 scoring. But then we are just doing also, of course, the sum of the 3, but we are applying also a decision tree behind, which is a little bit more, let's say, complex than the one used by Myriad. And why, in fact, we can do it, it's because the calculation is done in Belgium and the report is generated on the cloud in Belgium. And there is no patent in Belgium. So that's why we are able to do it.
Okay, thank you very much.
You're welcome.
Yeah,
And
Umut, in the literature, as you know, PIK3CA mutations are second most common prevalent in endometrium cancer after PTEN mutations. So it's very common, but it also shows bad prognosis, poor prognosis. So even in low-grade tumors, it's a poor prognostic to have this mutation. So I think your questions are very relevant for this patient. You need more treatment options. You will need in the near future. Pembrolizumab, lenvatinib, yeah, it's actually standard treatment in endometrium cancer, so it's acceptable. Regarding alpelisib fulvestrant treatment, I don't know. We don't have an exact answer for this, but why not to try? I'll say.
yeah, I had a patient last year. She presented after adjuvant treatment, brain metastatic, but more than 100 metastatic lung nodules, endometrial carcinoma.
Wow.
We found the PIK3 mutation, and in that time, the patient performance status is not good, not tolerate any chemo. We started with alpelisib, just alpelisib, and near perfect response, more than 90% resolution of the tumor. But after 7 months, the tumor recurred. Again, the worst one, and we lost the patient after 2 months. It works, but just a case. Maybe in this case, another patient for the treatment.
Right. Any other comments from participants?
Yeah.
Hi, Dr. Dermisi. Is this patient's tumor a serous type or endometrioid type?
Yeah, it's a valuable question because the first operation, endometrioid adenocarcinoma reported, and then papillary adenocarcinoma, the second one. And I asked the pathologist, is this same? Yes, these are same and papillary histology, but not serous.
So if it's not serous and you're thinking endometrioid, you
Yeah.
always give about
endometrioid. Yeah, you are right.
You give chemo. Usually you give about 6 cycles. They start struggling with neuropathy, and then you will have neither a treatment break or you give something. So if you didn't know about the PIK3CA or we didn't detect that, would you give hormone treatment? Is the is the other question, because
estrogen receptor positive also.
and then if you are going to draw the conclusion from breast cancer, you would look for the CDK6, and you would think about things like palbo or abemaciclib. So if you're going out, my question to you is, would you go beyond just alpelisib? Would you go for CDK type?
It's not because no any clue in the NGS testing. For example, cyclin A, cyclin D amplification is not. I'm not sure.
And that comes back to Sebastian. Is there any test for abemaciclib as well?
Unfortunately, no, nothing. Nothing is clearly working, except I think we can have some proof about, let's say, like you said, the amplification of the cyclin, but yeah, except that there is nothing.
Any more questions, comments? I think no. Thank you, Umut. It's very interesting
Thank you very
case,
much.
and we would like to hear about the progress of the patient in, the coming tumor bursts.
In couple months, yes.
Yeah. And now the fourth case, the last case, will be presented by Dr. Özge Keskin. She's a Turkish medical oncologist based in Bahrain. So hello, Özge.
Hi,
The
good
podium is
afternoon.
yours.
Good afternoon. Can you hear me?
Yes.
Okay, perfect. Because like I had a problem about the call and the voice. Still, I had a problem about sharing my presentation. So if the team can help me, I will appreciate.
Yes, with pleasure. We will share your slide right now.
I don't know what happened, but I cannot see the bar to share. Okay, perfect. Thank you. So I will just try to share my case with metastatic pancreatic adenocarcinoma. Can we proceed? She is 46-year-old female with having very good performance status at the time of diagnosis, just having asthma as a medical history. There was no obvious surgical history. There was no family history, and she was investigated for upper abdominal pain like 2 years back. Next slide, please. Then for this upper abdominal pain, she was investigated with ultrasound, liver, and biliary, and there was pancreatic head mass, which was causing kind of obstruction and dilatation of both intra and extrahepatic ducts. Then by gastroenterology department, CT chest and MRI liver was done. Again, it confirmed the pancreatic mass, which was inseparable from medial wall of second part of the duodenum and like close relation with the major vessels. There was dilatation of intrahepatic biliary radicals. There was a suspicion liver lesion in segment 4A. There was some intra-abdominal lymph nodes, and in the chest CT, there were multiple bilateral lung nodules. Next slide, please. So a biopsy was done by the gastroenterology team, and it was reported as positive for malignant cells consisted with pancreatic adenocarcinoma. Internal biliary staining was done at that time. The first one was like at the time of diagnosis, exactly April 2021, and the second one end of May. And like till end of May, she was not able to receive any treatment because of elevated liver functions and this obstruction, biliary obstruction. Then started with FOLFIRINOX. She received a very short time period. It was just like 3 doses of FOLFIRINOX. Then she had progression, clinical progression, and radiological progression, especially in primary area. There were new liver lesions. The lung nodules were stable. Then she was started on second-line nab-paclitaxel plus gemcitabine, and actually it was a great response with the second-line treatment, and it kept the disease under control almost for 1 year. But at the end of 1 year, September 2022, the liver lesions were progressed in size and in number. All these investigations were done with CT scan. At that time, we sent for, if you can just go like next slide, we did BRCA test from liquid biopsy, and it was reported as negative. Then planned for third-line treatment, as she was having a good response with gemcitabine, nab-paclitaxel, kept gemcitabine but added cisplatinum, and she just received 3 doses. Again, there was a progression, especially in the liver lesions in terms of size and number of the lesions. Still, she was having like ECOG performance status of 0 to 1, and like 4th line single agent capecitabine we started on November 2022 until April. She was receiving that one, but in April there was an extensive progression. Now it was like progression in the liver lesions, new peritoneal deposits were there, and there were new intra-abdominal enlarged lymph nodes. Okay. While I was planning for agent capecitabine, like she was in the position that received almost all appropriate treatment options. So at that time, we discussed in our MDT meeting and agreed on to do liver biopsy, especially from the lymph lesions, and to send it for like OncoDNA analysis.
it's quite taking some time for us, for our center to get the results. Actually, it was like at least 4 weeks. We did the liver biopsy, sent it for analysis, and at the same time, because she was having progressive disease, planned for gemcitabine erlotinib, but she was just able to receive 1 dose for gemcitabine and just few weeks of erlotinib. Then we admitted her for fever from unknown primary. Then after stabilization of her without fever and such, we discharged. And now I just shared the molecular analysis we did during the whole treatment course. This liquid biopsy, the aim was to check actually the BRCA status. We did it during second-line therapy and was reported as negative. Then we checked KRAS mutation later on. Within the next slide, we can see there was KRAS mutation in codon 12. Then finally, when we started with capecitabine, we did OncoDNA tumor profiling. And now here in OncoDNA tumor profiling, BRCA2 was reported as pathogenic. As you can see, HRD negative, MSI was stable, and tumor mutation burden was high. So I will appreciate if anyone can just express opinion. My presentation is just this, the recommendation for any next line of treatment. Thank you.
Thank you, Dr. Özge. Sebastian, would you like to comment on these findings?
Yes, this is I would say an interesting cases. My concern here probably is that I'm not sure about the mutation. I would say, we detected the BRCA2 mutation, but I'm not sure why this mutation is there. Because the tumor mutational bundle is high, and when you look to the allelic frequency of this variant, it's really low. So and as you said, you tested BRCA1 and 2 in liquid biopsy, and it was completely negative. So from my point of view, probably this variant is there because of the TMB. Which is not really, I would say, very common in pancreatic cancer. But yes, sometimes it occurs that the TMB is high. It's not that high because I think it's, I don't remember exactly, but close to 11, something like that.
Yes.
So yes, from my point of view, regarding what you already tested, probably I would go for immunotherapy just to see if the patient first can succeed to receive the treatment, and then the beneficial effect of the treatment.
Yeah,
Sebastian, can I ask you a question about the tumor mutation burden? For this case, 11 looks like 11, which is more than 10. But if we consider the just pancreatic cancer origin, median tumor mutation burden, how is it for the pancreatic primary? How much high? I'm trying to understand.
Yeah, I honestly have to check this regarding the I would say the database, but probably it will be lower than 10. It will be lower than 10 because, of course, the pancreatic cancer are less mutated than for non-small cell lung cancer, mainly the one used to put the threshold. So probably it's less than 10. So I don't have any, let's say, concern about the result. For sure, it's TMBI.
Sebastian, I have one question. Do you have the tumor cell content?
Yes, 60%. So it's not that bad.
Okay, so either the explanation is a TMB or it's a subclonal, the BRCA2 mutation.
Yes,
And
yes.
in any case, we don't have any second hit, so we can not go with PARP inhibitor. So yeah.
So and even moreover, the patient, yes, the patient stopped platinum belts, the salt chemotherapy very fast. So not sure.
Yeah.
Dr. Keskin, congratulations, your patient is still alive after such a long time. So if it is truly pancreas cancer, you've done well there. And this is unusual. So the median survival of my pancreas stage 4 would be 3 to 6 months. So you've done well there to get through so much treatment. The second thing is, Sebastian has already mentioned, I think if you're platinum resistant, I don't think they're going to be BRCA positive. Even if it is, I think it is wrong, because usually they don't get tested because they progress so quickly clinically. They're not. But with the TMB high, I've in the UK, because of where I practice, the patients may not have insurance. I've written to Pembro and Nivo, and occasionally they give compassionate access. I don't know whether they still give it in the UK. I think they've stopped since last year, so I can't get access to immune checkpoint inhibitors. There is no data in pancreas primary. What I query is, are you sure this is pancreas, or is it more of cholangioampullary type? Because if it's ampullary type, then they do behave a little bit better, and this is why I think your patient may be a slightly better prognosis, because of the primary is probably ampullary rather than pancreas. But I think you've done very well there to get this patient 2 years. I have nothing else to add. I think you have to try whatever you can get your hands on.
Yeah, this is one of the questions we discussed within our department. Like, you're right, it's the clinical picture is not looking like metastatic pancreatic cancer, but the thing is, the radiologically, and the biopsy was taken from the pancreatic head mass. So yes, the clinical progress is not looking like, but
First line of therapy failed very quickly for FOLFIRINOX. Is there any genetic abnormality can explain this unresponsive situation, Sebastian? Except ERCC positivity?
No, I don't see anything yet. But why you have, let's say, I would say, bad prognosis mutation like TP53, but like the cancer. So probably yes, the tumor is probably really aggressive, and then finally she relapsed very fast under chemo.
Any
Well, Sebastian,
counterpart
he's had 2 years, so he's not bad. It's
Yeah, well,
actually
it's
quite
not that
good
it's not
result.
that bad. It's not that bad. It's not that bad.
If we wish to add any chemotherapy to immunotherapy, what is the best option according to this abnormal genetic test results? Is there any counterpart we can consider?
But we don't have biomarker to predict resistance to chemotherapy regarding the NGS. So if you look to the clinical history of the patient, I would try nab-paclitaxel or gemcitabine with the Pembro.
She already
received, yes, like almost 1 year.
Thank you.
Thank you.
You're welcome.
Good luck, Dr. Keskin. Well done.
Yeah, I have a comment.
Yes.
I have a technical comment on the BRCA mutation. So you know that there are lots of poly N regions in the BRCA genes. Did you check whether this variant was somewhere in a poly N region? So that maybe
this is situated in a stretch of A. But as it's captured, it's not. Let's say it's for sure it's there. It's not a mistake. But yeah, for my
VFF 11% can indicate that this is slippage. Yeah.
Yes.
Thank you. Actually, this was very interesting discussion, and this difficult case with a long survival for pancreas cancer. So I hope we get more, we get better survival results for this patient with different treatments. Now I'd like to thank OncoDNA group for giving us this opportunity to discuss these interesting cases. I would like to thank Sebastian especially for his contributions, and also I would like to thank our speakers for sharing their cases with us. And actually, I'm very impressed with this tumor board. We had more than 60 participants from different parts of the world. This is really international molecular tumor board with very interesting cases. And I think in the future we will have more molecular boards which will be helpful for our patients in the routine daily practice. It's not now only laboratory based tests, it's also clinically important tests which gives different treatment options to our patients. Again, I would like to thank everybody, all the participants for having this molecular tumor board with us. Good afternoon. Thank you.
Good afternoon,
Okay.
everyone.
Thank you.
Bye.
Thank you.
Bye-bye. Bye-bye.
Thank
Thank you
so
very much.
Bye-bye.
Bye.
Bye.
Everyone.
Bye.
Bye.
Thank you.
So bye-bye, Julia.